Welcome. Cool. Welcome, everyone. So G-ECHO is hosted by Gastro Foundation in association with Project ECHO, University of New Mexico. It runs every second Monday at 6 p.m. And just to remind you that the chat is open for questions and I'll be monitoring it. Our presenter for today is Dr. Jill Gaskin, and she will be taking us through autoimmune liver disease. Over to you, Jill.
Good evening, everybody, and thank you for the introduction, Dr. Gogela, and thank you for your kind assistance in preparing for today's talk. As mentioned, we will be discussing autoimmune liver diseases. So, as an outline of the talk, we decided today to focus more on some of the practicalities of the day-to-day diagnosis and management of autoimmune hepatitis and primary sclerosing cholangitis, and then spend a little bit more time on primary biliary cirrhosis, including reviewing the new drugs that have recently become available. Before concluding, we will also briefly discuss overlap syndromes. So as we know, autoimmune hepatitis, primary biliary cholangitis, and primary sclerosing cholangitis are the three major forms of autoimmune liver diseases. They are complex, rare diseases that have similar immune-mediated pathogenesis in genetically predisposed individuals, but they differ according to their site of autoimmune injury, the pattern of inflammation, as well as the clinical phenotype. Together, these diseases contribute significantly to the burden of chronic liver disease, including healthcare-related costs, and they greatly impact quality of life on an individual patient level. All three disorders have a progressive course that, if untreated, develop into end-stage liver disease requiring liver transplantation. And the aim of treatment, therefore, is to abolish or reduce inflammation, reduce cholestasis, and limit the progression of fibrosis. So the first one we will be discussing, autoimmune hepatitis, is one of those medical enigmas that often pose a diagnostic challenge, partly due to its rarity, but even more so due to the extremely heterogeneous presentation, as well as the lack of definitive standalone diagnostic tests, and the fact that the patient's response to first-line treatment, by the way, that has been available for the last 50 years, is actually very variable. So we are often faced with patients referred with abnormal liver function tests, particularly elevated transaminases, and we may have a bias to consider a differential of autoimmune hepatitis in a young female patient, perhaps with personal or family history of autoimmunity. While, yes, this is good to consider, we need to be equally aware of the fact that autoimmune hepatitis can present in any racial group, both male and female, at any age, from infancy to old age. Yes, even the 60-year-old lady could present for the first time with autoimmune hepatitis. The picture here is just to imprint in our minds that we should always consider the differential diagnosis of autoimmune hepatitis and screen for it when patients present with hepatitis or a hepatic picture with or without jaundice. This diagram shows us just how heterogeneous the clinical presentation of autoimmune hepatitis can be. You can meet a patient at any point along the spectrum. They may have a purely acute presentation without any underlying cirrhosis, either picked up incidentally when abnormal liver function tests are found, or the patient can present with a more insidious onset characterized by nonspecific symptoms like fatigue, arthralgia, malaise, amenorrhea, right upper quadrant pain, and fluctuating jaundice. And then more severe presentation with jaundice, markedly elevated transaminases above 5 to 10 times the upper limit of normal, and an elevation in the INR greater than 1.5. These characterize the acute severe autoimmune hepatitis presentation. Fulminant liver failure requiring supportive measures and liver transplant, which is rare, occurs in about 3 to 6% of patients, but it's an important presentation to recognize, especially because usual diagnostic tests may not always be positive in that setting. Up to a third of patients at diagnosis have already developed cirrhosis, and they can present with decompensated disease, including acute and chronic liver failure and complications of portal hypertension. What's also interesting to see is how patients can move from exacerbation to compensation, either by spontaneous remission or by therapeutic intervention. Or they can progress, or they can have progression of disease despite treatment. During these various presentations, viral hepatitis, drug-induced liver injury, metabolic liver disease, and alcohol-related hepatitis, which are the main differential diagnoses, could even coexist or be a cause for decompensation in a patient, or a flare in a patient with established autoimmune hepatitis. So how do we make a diagnosis? Like I said earlier, there's no single or standalone diagnostic test. Instead, it's a constellation of biochemical, serological, and histological features that, when put together, provide a definite or probable diagnosis of autoimmune hepatitis. Over the years, the International Autoimmune Hepatitis Group have put forward and revised various scoring criteria to aid in diagnosis. I haven't obviously included all of these scoring systems. Some are a bit more cumbersome. This one, though, is called the simplified scoring system. It's easy to use and has an excellent positive and negative predictive value. Let's have a look at the different parameters. So firstly, demonstration of autoantibodies is an important component of the diagnosis of autoimmune hepatitis, but bear in mind that not all patients, or there is the entity of seronegative autoimmune hepatitis as well. So the conventional autoantibodies are ANA, anti-nuclear antibodies, smooth muscle antibodies, and anti-liver kidney microsomal 1 antibody, which are widely available, and their presence, especially at high titers, add more weight to the diagnosis. They do also have a limitation of being non-specific. They can be positive, especially they can be falsely positive, especially in the elderly. They can also be present in drug-induced liver injury. Whereas the soluble liver antigen, liver pancreas, is actually more highly specific for the diagnosis of autoimmune hepatitis, but it's not always available. So we'll also look for specific elevations in immunoglobulin G, IgG, which is characteristically present in about 90% of patients, and should always be checked. Just to be aware that in patients with a very acute presentation of fulminant autoimmune hepatitis, this characteristic IgG elevation may be missing. Then obviously there's additional points that are added for typical histology, which we will discuss in the next slide. And then lastly, the absence of viral hepatitis also strengthens the diagnosis. So we know that liver biopsy has kind of fallen out of vogue in the era of non-invasive fibrosis assessment, but one condition where it is a non-negotiable is in autoimmune hepatitis. So making the diagnosis without histology should be an exception and limited to very special clinical situations. Not only does histology assist to confirm the diagnosis, it can also assess degree of inflammation, degree of fibrosis, and it can exclude alternate diagnosis. In patients with cirrhosis, there may be considerable histological activity despite normal aminotransferase levels. Therefore, in these patients where you suspect cirrhosis from autoimmune hepatitis, a liver biopsy should be performed irrespective of the transaminase levels. But on the other hand, in a patient with no signs of advanced fibrosis, which can be confirmed by liver stiffness measurements, liver biopsy should actually be deferred if the aminotransferase levels are normal, because we know autoimmune hepatitis can be a fluctuating disease, and a liver biopsy performed in a phase of spontaneous remission may actually miss the diagnosis. Regarding histology, one is to make the disclaimer that no histological feature is specific or pathogenomic of autoimmune hepatitis. An interface hepatitis, which is commonly seen, can also be seen in drug-induced liver injury or viral hepatitis. But as a typical feature, though, it is present in 98% of patients with autoimmune hepatitis. The other two features that were previously considered important in autoimmune hepatitis were imperiopoiesis and hepatocellular rosettes. But recently, these have been removed in an updated pathological criteria for diagnosis of autoimmune hepatitis by the International Autoimmune Hepatitis Pathology Group in 2022. And this is because imperiopoiesis and rosetting have in various studies been shown to be entirely non-specific, and their expression is of the severity of liver inflammation rather than its cause. So here we see this updated diagnostic criteria. And what's particularly important about the new consensus features is that traditionally the features of that we would consider characteristic of drug-induced liver injury, like lobular, in particular central lobular hepatitis and necrosis, are actually now considered a possible histological expression of autoimmune hepatitis, particularly when patients present with an acute presentation. We see here that the likelihood of autoimmune hepatitis can be confirmed with either a predominant portal hepatitis or a lobular hepatitis pattern in the absence of histological features to suggest an alternate diagnosis. So the aim of treatment is to obtain complete biochemical remission, and this is done to prevent progression and even allow for fibrosis and cirrhosis regression. Most, if not all, patients, once the diagnosis is made, will require treatment, induction and maintenance therapy with corticosteroids and azathioprine as the backbone of treatment. There may be a small subset of patients who are asymptomatic that enter spontaneous remission with the ALT level less than 3 times the upper limit of normal, low hepatitis activity index on the biopsy, and no evidence of fibrosis. These patients, especially in the setting of older age or significant comorbidity, may be given an option of no treatment, but instead close monitoring, including the need for a liver biopsy if required, and treatment as required during the monitoring phase. So all patients should have a pre-treatment evaluation to limit treatment-related complications. These include screening for thiopurine methyltransferase activity to identify patients at risk of severe myelosuppression. They should have their vaccination status updated and vaccinated against hepatitis A and B if they're not immune. They should have bone density assessments at baseline and then every 2 to 3 years. While on corticosteroid treatment, elemental calcium and vitamin D should be supplemented. And then obviously the effects of autoimmune hepatitis, cirrhosis, and the medication on fetal maternal health should be discussed with our young female patients. So regarding the initial treatment approach, it's slightly different depending on the circumstances, like the presence of an acute severe presentation, the presence of cirrhosis, which would be treated slightly different than someone presenting without complications. Generally, well patients with confirmed autoimmune hepatitis with or without jaundice should receive an induction dose of 0.5 to 1 milligram per kg per day of prednisone. Another option includes budesonide, which has a 90% first pass effect on the liver with less systemic side effects. The patient is reviewed, and then within 7 to 14 days, if there is an adequate response, then azathioprine can be introduced at a dose of 1 to 2 milligrams per kg per day, with subsequent tapering of the steroid dose and, if possible, complete steroid withdrawal and maintaining the patient on azathioprine with frequent monitoring. In a patient with cirrhosis, it's best to use prednisone and avoid budesonide because portosystemic shunting reduces the efficacy and it also promotes systemic steroid side effects by bypassing the liver. One should also avoid azathioprine in patients with decompensated cirrhosis. So once you have initiated prednisone, it's then necessary to monitor closely for response. And if a patient has achieved recompensation, at that point, you can consider adding azathioprine with the steroid taper. In the acute severe disease, only high-dose prednisone should be used with very close laboratory monitoring. And if a poor response in 7 to 14 days is noted, one should reevaluate the diagnosis, consider second-line treatment. But if at any point there's the development of encephalopathy, urgent referral for transplant would be required. Favorable response to prednisone in this acute setting would then obviously require the addition of azathioprine with steroid wean later on. So we don't really have time to delve into the study, but I thought it would. It's a good study that highlights mycophenolate mofetil as a potential alternate to thiopurine as first-line therapy. This recently published randomized controlled trial directly compared the thiopurine and MMF, both in combination with prednisone, for the induction of biochemical remission in treatment-naive patients with autoimmune hepatitis. What came out of this was an improved efficacy signal and low adverse event rate compared to azathioprine, which could perhaps favor MMF as a standard first-line therapy for remission induction. However, long-term maintenance data, potential teratogenicity, availability of MMF, and the cost may be a limiting factor to more widespread use. But irrespective, once treatment is initiated, close monitoring of patients is critical, not only to assess response to treatment, but to also pick up treatment intolerance timeously. Treatment intolerance, which is defined as an adverse event related to treatment that leads to discontinuation of the drug, can occur at any time during the course of treatment. Things like myelosuppression, pancreatitis, worsening hepatitis. And ultimately, the goal of treatment is complete biochemical response, which is defined as a complete normalization of ALT and IgG at 6 months. If non-response or inadequate response is identified, always consider adherence, reassess diagnosis, consider going back to high-dose steroids. Long-term remission is possible, and at some point, some patients may wish to stop treatment. This should only be considered in patients whose initial presentation was not a severe or fulminant presentation, and they should have a sustained biochemical remission for at least 2 years, as well as histological remission with the hepatitis activity score of less than 4 on the pre-withdrawal biopsy before that decision can be made to stop treatment. And once treatment is withdrawn, patients require extremely close follow-up, especially in that first year, to monitor for relapse. And obviously, if relapse does occur, they should be placed back onto the original regimen that induced remission. So what to do when a patient has failed to respond to or is intolerant to the first-line treatment with azathioprine? So available data here is limited. There's obviously a definite need for further research on this front, but because of small numbers and lack of standardization, we don't have, this information readily available. This position statement guideline from the IAHG and European Reference Network that was published in the Journal of Hepatology in 2020, they actually advocate for separating the approach to the rescue treatment in those who have had a failed response or an insufficient response and those who are intolerant from side effects to standard treatment. So separating the two approaches, they feel that separating it will assist with better defining future research participants as this rescue therapy research evolves. But also, it's important to know that patients who fail azathioprine are unlikely to improve with MMF. So they obviously need to then move to the third-line drug options. So let's look at this in patients who have had an insufficient response. They failed to respond to steroids and azathioprine. The active metabolite 6-thioguanine should be measured. So obviously this guideline presumes that 6-TGN monitoring is available, and unfortunately we don't have that. But in the ideal world, the treatment doses of azathioprine would be optimized, guided by the levels, obviously after excluding non-compliance. In patients with autoimmune hepatitis not achieving a full response despite adequate levels of the 6-TGN, and if a concomitant diagnosis or alternate diagnosis is not found, then patients you should move on to third-line treatment. If a patient is found to be intolerant to azathioprine because of side effects, you can switch to 6-mercaptopurine, and up to 75% of patients will tolerate 6-MP as an alternative. And a second alternative there obviously would be MMF. And if patients then fail to respond to these, one would need to move on to third-line drugs. Of the available third-line drugs, tacrolimus is the most studied one. Meta-analysis that included about 9 studies found that patients taking tacrolimus achieved biochemical remission rates at about 68.9% in these refractory patients. All the other listed drugs have been used anecdotally, small number trials, and the anti-TNFs were used in the context of patients with IBD, where they found that the liver function, where they had patients that concomitant IBD, and they found that the liver function improved. Okay, so moving on to primary sclerosing cholangitis. So as an introduction, PSC, which is most commonly associated with inflammatory bowel disease, it runs a progressive course alongside a heightened risk of hepatobiliary and colorectal cancer. Obviously, medical therapies here are lacking, so the current treatment is largely supportive, and liver transplant is an effective life-prolonging intervention when it's needed, but not one that cures the disease. So how do these patients present? Well, most are asymptomatic at the time of diagnosis and are discovered incidentally when abnormal LFTs present as elevations in the cholestatic enzymes. And this can either be found as part of routine IBD care, or if the biochemistry is performed for whatever other indication. Patients can have fluctuations in their serum liver tests. This is common because of the variable nature of the bile duct obstruction caused by strictures, stones, and sludge. So that's important to note. And patients could even present with, obviously, the signs and symptoms that can develop as the disease progresses and fluctuates, things like jaundice, pruritus, fatigue, sleep disturbance, weight loss, urine and stool color changes, abdominal pain. And then obviously they could also present with biliary cirrhosis and the complications thereof. So an approach should start with a detailed history and examination, including the assessment of severity of symptoms, exclusion of toxins or drugs, details regarding comorbid disease, including the presence of IBD or the symptoms thereof. One should early on exclude extrahepatic biliary obstruction with an ultrasound of the liver, and then obviously a positive antimitochondrial antibody will take you down the route of investigating for PBC. So the next step in a patient with suspected PSC would be to perform a MRCP to confirm the presence of biliary strictures. While ERCP has long been considered the gold standard, its use has now largely been limited to therapeutic intervention. MRCP is shown in multiple studies to have comparable diagnostic accuracy to ERCP. So importantly, if biliary strictures are found on imaging, it could also represent secondary sclerosing cholangitis, which is an important differential diagnosis that can often be indistinguishable at cholangiography. Secondary sclerosing cholangitis is less common than PSC, but its prognosis is generally worse depending on the underlying cause. Some cases may resolve spontaneously, while others can rapidly progress to cirrhosis and require transplant. Some causes of secondary sclerosing cholangitis may respond well to medical treatment, and it's therefore important to exclude them before making a diagnosis of PSC. So the list of causes, as you see, is a very long one, but one can be guided by the history and examination, as well as by tests like HIV antibodies, serum angiotensin converting enzyme, total immunoglobulins, and immunoglobulin subsets like IgG4. So then ultimately making a diagnosis of PSC, we see it's largely imaging based. You get the typical cholangiographic features on MRCP in the absence of any other identifiable cause of secondary sclerosing cholangitis. And obviously this is in the context of a clinical and biochemical presentation of cholestasis. You notice I didn't mention serological tests for the diagnosis of PSC. That's because unlike PBC and autoimmune hepatitis, autoantibodies have minimal diagnostic implications for PSC. So the typical findings at MRCP include multifocal stricturing of the intrahepatic and extrahepatic bile ducts. There may be bile ducts with intervening segments that are relatively normal in caliber or that are mildly dilated, and that gives that characteristic beaded appearance. You can get intraductal stones, you can see changes in the cystic duct and the gallbladder. And as the disease progresses, strictures worsen, ducts become obliterated, fibrosis and cirrhosis becomes evident. So given that the diagnosis of PSC is largely imaging-based, is there a role for a liver biopsy? Well, yes, one would perform a liver biopsy if small duct PSC is considered, if there's a concern for alternate liver disease or an overlap with autoimmune hepatitis, then a liver biopsy can be performed. Small duct PSC is the less common variant of PSC that has the typical cholestatic and histological features of PSC, but you have normal bile ducts on cholangiography. It may actually later develop to classic large duct disease at a rate of 14 to 23% over a period of about 6 to 7 years. The most classic findings of PSC on histology is onion skin fibrosis, which is concentric fibrosis surrounding the large bile ducts. And as the disease progresses, there's bile duct loss and fibro-obliterative lesions or scars that actually replace the bile ducts within the portal tract. Up to 70% of patients with PSC have inflammatory bowel disease, 2/3 UC, and 1/3 Crohn's disease or indeterminate colitis. Therefore, patients with PSC who do not have a known IBD diagnosis should have an ileocolonoscopy with biopsies at the time of PSC diagnosis to obviously screen for asymptomatic colitis. If no colitis is detected, then ileocolonoscopy with biopsies should be performed at 5-year intervals or at any point if symptoms suggest IBD. The phenotype in terms of disease location and activity in patients with PSC is different compared to classic UC or Crohn's disease. The colitis in PSC IBD typically presents with extensive inflammation, but it's usually with milder activity. You get pancolitis with or without backwash ileitis is common, and then inflammation is most active in the proximal colon, and the rectum is relatively spared. So since the combination of IBD and PSC is associated with a higher risk of colorectal cancer, which is actually 5 to 12 times greater than compared to the general population, and 4 to 5 times greater compared to patients with IBD without PSC, one should always then aim for close disease control, make sure the IBD is well controlled, along with annual surveillance for dysplasia and early pickup of colorectal cancer or pre-malignant lesion. So at present, there's no approved medication for the treatment of PSC. None of the treatments are proven to halt the disease progression. So the management revolves around recognizing and treating the complications. Ursodeoxycholic acid, a secondary bile acid, it's a hydrophilic epimer of chenodeoxycholate. In this meta-analysis, it's shown that UDCA has no beneficial effect on patient survival, liver histology, prevention of cholangiocarcinoma, or improvement in clinical symptoms. But what they have found that it is associated with improvements in serum markers of cholestasis, and they found that if patients discontinue their treatment, it can lead to deterioration in symptoms and enzymes. So because of those findings, as well as other studies that show that patients with PSC who achieve normalization of their ALP, they have an improved prognosis. So this is why in the most recent consensus advice from the AASLD in 2022, they recommend that patients who are not eligible for clinical trials and that have raised ALP-GDT levels, they should be offered a trial of low to moderate dose UDCA, and that should be continued for up to a period of 12 months and continued if there is an improvement. So many other immunosuppressive, antimicrobial, antifibrotic agents have been investigated to treat PSC, but no drug has been found to alter the natural history. And there are many drugs that are currently being evaluated or considered as a treatment of PSC. So this is just something to watch. So obviously it leaves us in trying to help our patients. We've got to manage the symptoms and the complications. Many patients have pruritus. It's a common prominent symptom that can be both severe and disabling and impact patients' quality of life, lead to social isolation and depression. So there isn't any approved treatment for cholestasis per se, cholestasis-associated pruritus, and UDCA hasn't been shown to be effective. In fact, it can actually make the pruritus worse. So an approach to the pruritus in a patient with cholestasis, obviously in the setting of PSC, one would need to, if there's a relevant stricture, one would need to assess that and obviously exclude the development of a cholangiocarcinoma. Once that's been ruled out or treated, Patients should be advised avoiding heat, hot baths, using topical emollients and antihistamines. And then if that fails, cholestyramine can be used. And then second-line therapies for refractory symptoms include sertraline, naltrexone, and rifampicin. And then this was an interesting trial, the Fitch trial, fibrates for itch, benzofibrates along with so what they found, this was a randomized trial of 74 patients, 46 had PSC, and these patients had moderate to severe pruritus. They found that 45% of the patients treated with benzofibrates achieved endpoint of 50% reduction in pruritus compared to placebo. But ultimately, in patients who fail to respond to medical treatment, they should be considered for liver transplant for refractory pruritus. So what is the role for ERCP in the management of PSC? Patients can require ERCP or even repeated ERCP at various points during their disease course. And the decision to perform an ERCP must always be carefully weighed against the potential risks. Risks of bleeding, risks of incomplete biliary drainage and cholangitis, as well as pancreatitis. And an MRCP should generally be considered prior to ERCP, just to clarify exactly, roadmap per se, but also to, just to identify the patients that actually need to have an ERCP. But some of the indications for an ERCP include, so you could have a patient, for example, that you suspect PSC, but you haven't been able to get an MRCP. For example, maybe the patient has claustrophobia or they have metallic implants, and you have a high index of suspicion, or the original MRCP is inconclusive, then ERCP can be used to diagnose PSC. But then other indications include severe bacterial cholangitis that has had an inadequate response to medical treatment. And then obviously where intervention is required for stone extraction or stricture management. ERCP is also required in patients who have developed a relevant stricture, which is defined as any stricture of the CBD or the hepatic duct that's associated with signs or symptoms of obstructive cholestasis or bacterial cholangitis. Usually these patients present with new onset or worsening pruritus. They have unexplained weight loss or worsening LFTs. They have elevations in their serum CA 19.9, or the MRCP imaging, which is performed in the setting, may show worrisome features or dominant stricture or features to suggest cholangiocarcinoma. In that setting, it's advised that an ERCP with ductal brush sampling and fluorescent in situ hybridization should be performed if it is available to rule out cholangiocarcinoma. So we know that brush cytology alone lacks sensitivity, only around 43%, but it does have good specificity for the diagnosis of cholangiocarcinoma. So this is why the fish is added to this to increase the yield. So then further management decisions and further follow-up of the patient will obviously be guided by the results of the cytology and fish, which can either diagnose cholangio or may be repeated in 3 to 6 months. So, and then in the cases of indeterminate biliary strictures, other options for diagnosis include intraductal forceps biopsy, endoscopic ultrasound, intraductal ultrasound, or even cholangioscopy with biopsy. So patients with PSC require malignancy surveillance. Those with large duct PSC, age above 20 years. HCC, hepatocellular cancer, is relatively rare unless patients have cirrhosis. So if there is cirrhosis, the HCC surveillance should be performed as one would for any cause of cirrhosis, with 6-monthly ultrasound and alpha-fetoprotein. And then PSC cholangiocarcinoma obviously can occur at any time during the course of PSC, but it's reportedly highest in the first year of diagnosis. And the evidence for the use of MRCP surveillance to try and pick up cholangiocarcinoma is lacking, but all the guidelines currently do recommend annual MRCP surveillance for patients with large duct PSC. The CA19-9, these can sometimes support a diagnosis of cholangiocarcinoma, but a normal level obviously doesn't exclude a tumor. And then CA19-9 levels can even increase from any cause of biliary obstruction in general. And then there's a subset of patients who don't even secrete it. So bearing those limitations in mind, in terms of surveillance, they say that CA19 is considered, 0.9 is considered an optional add-on. Gallbladder cancer is 9 to 78 times greater compared to the general population in patients with PSC. So the polyps that we might see are considered pre-malignant, and if a patient on annual ultrasound is found to have a normal ultrasound, this can be repeated annually. But obviously, if there is a polyp less than 8 millimeters, that can be monitored 6 monthly. And if there's a polyp greater than 8 millimeters, the patient can be considered for cholecystectomy. We have also already discussed the need for colorectal cancer surveillance in PSC IBD. So PSC accounts for approximately 5% of liver transplants. Interestingly, in the WITS transplant unit, in the reports that was published in the SAMGA, the most common indication for transplants each year between 2018 and 2022 was for cholestatic liver diseases. So typical transplant indications for PSC are life-threatening complications of cirrhosis and portal hypertension, intractable pruritus, recurrent bacterial cholangitis, and early-stage cholangiocarcinoma. So the patient and graft survival is comparable to other diseases, and recurrence occurs in about 10 to 37% of recipients. So lastly, let's discuss primary biliary cholangitis. It's a progressive autoimmune liver disease where patient outcomes are largely dependent on early recognition
Jill.
and response.
Hi, Jill.
Hi.
Hi. Sorry, Jill, to disturb your excellent flow. There's a few questions or comments rather on the chat. Perhaps a compliment from Zamo says you're giving us a tour de France, proper, beautiful, practicalities in diagnosing and managing patients with autoimmune liver disease and now PSC. So Mzamo's first question is regarding autoimmune hepatitis. What proportion of patients will recur or relapse after withdrawing treatment? Any factors associated with successful withdrawal of immunosuppression? Do you want to answer that?
Yeah, so obviously you wouldn't want to withdraw in patients who had originally had quite severe disease. So that might be a factor that's associated with recurrence after withdrawal. But I'm not sure regarding the other factors. Perhaps you can clear that.
Okay. Yeah, so it's a difficult one, Mzamo. I can't really give you the numbers, but I can say for sure that probably less than 0.001 of our patients manage to get away without therapy. And I think, as Jill said, if patient presents with severe disease, you wouldn't dare try and withdraw, or rather give them a treatment break. The guidelines do suggest that if patients achieve biochemical or histological remission, one can sort of try to give them that treatment break. And if you measure like your IgG level as well, you can use that to decide who you can afford that treatment break. But what we usually do will induce remission with high dose spread, and high dose, I mean max is really 30 milligrams. And once they are out of that cholestatic phase, we then introduce a second sparing agent, and in this case it will be AZA. And if they don't tolerate AZA, we will go straight to MMF, and we maintain them at maximum dose for autoimmune we usually give is really around 150 of azathioprine. And MMF, some patients tolerate up to a gram BD, especially those that are non-cirrhotic. And with time, as you follow them up and they achieve really biochemical remission, we never biopsy them to prove that they are in histological remission. But once they achieve biochemical remission with normal IgG level, one can sort of maybe just withdraw the prednisone part of it, but not the steroid sparing agent. So that's how we manage our patients with autoimmune disease. And I want to make a stress a very important point with regards to the term treatment failure. Often in our experience, or my limited experience, is that equals to 100%, or if not 99 maybe percent of the time. That means that treatment failure is treatment phobia, right? People hate taking prednisone because it makes them fat. It's got really intolerable side effects. So often the patients that are labeled as treatment failures are patients who are really, really not taking their treatment. So what we do is then we bring them in and we explain and we observe and we really emphasize that you're better off with your liver, because a new liver will mean your body are taking your liver and now the stranger's liver. And it's truly the same drugs that you're going to use. So I don't recall any of our patients even going to tacrolimus or cyclosporine. We often get away with just using prednisone with either AZA or MMF. So when they say they're failing, it's very, very important that you squeeze in that compliance history. I've no experience in using rituximab. I know it's there in literature, even in patients who present with severe or recurrent or really what is termed treatment refractory autoimmune hepatitis. I hope that answers your question, a mouthful, but I think a good old prednisone and or your AZA or MMF, I think does the trick in patients who are really compliant with their medication. Also for the junior guys, Jill is gonna join the crew of gastroenterologists, and you'll be seeing a lot of these patients. I always say to our fellows and or medical registrar that with liver disease, the key is patience. The guidelines give you the 2 weeks, give you the 4 weeks. There's no rush in managing these patients. You can keep them on prednisone for almost 6 months before you even achieve a biochemical remission. So there's no I've been giving this for 3 months, they're taking it and things are not settling, you want to add on. Just steady does the trick when managing, and requires a lot of patience from the treating physician and the patient that's being treated to actually achieve the best results in the long term. And again, just to emphasize, guys, anyone can be affected by autoimmune, and often people want that positive autoantibody. And please do not be caught out by that 20% that have seronegative disease. And like Jill has mentioned, histology here is the key. And if you can't do, or if you can't access histology for whatever reason, be it they are coagulopathic or they've decompensated, it's never too late to attempt one when you've achieved some form of compensation, either via transjugular biopsy or a plaque liver biopsy if the liver is within reasonable size. And then, sorry, the next question is about pruritus and the the bile acid transporter in the ileum inhibitors. Well, hopefully that's something we will get in the next decade in our neck of the woods. We don't have it available, so pruritus is still a nightmare for us to manage in patients with cholestatic liver disease. perhaps maybe, people that are predominantly in private can comment on that if they have any access in the IBAT inhibitors, as asked by, again, Zamo in the lower chat. I'm happy to entertain a few more comments from the senior citizens in the panel. Okay. Well, there's a lot of comments coming from relapse following treatment. I think we're all in agreement that they do relapse, and I mean, you really need to monitor them very, very closely if you're going to withdraw therapy. And I think VG also echoes and says they do relapse. Dominic, is there a particular score used to determine the timing for liver transplant in PSC cases, given that the MELD is a challenge? Jill?
So for a lot of the indications for transplant, you get additional points added, MELD exception points that are added in the context of these cholestatic liver diseases. So in terms of other scoring systems, there's a whole lot of scoring systems that are used as predictors, but not necessarily, or predictors of progression and the requirement for transplant. But in the context of transplant specifically, it's those MELD exception points that help these patients get onto the list.
Okay, cool. Yeah, that's excellent. Jill, we are left with 10 minutes. I think there's exciting things on PBC, so I'll hand over to you. Thank you.
Okay. PBC. So the diagnosis of PBC should obviously be suspected in patients with cholestatic abnormalities in their biochemistry, particularly the ALP and GGT, or increased bilirubin and IgM levels can also be seen. These abnormalities in the biochemistry can also occur with symptoms like pruritus, Sika syndrome, arthralgia, fatigue. So one should always obviously take a good history, carefully exclude drug exposure, look for coexistent autoimmune conditions in the patient or the family, perform a thorough physical exam, including looking at the skin for xanthomas, xanthelasma, excoriation, and hyperpigmentation. Also, obviously, look for hepatomegaly, splenomegaly, and other extrahepatic signs of advanced liver disease. So this list shows commonly associated conditions that can be seen in patients with PBC, with 80% of patients presenting with Sika syndrome. And then obviously things like thyroid, celiac, scleroderma can also be seen. And then following on, patients require laboratory testing to assess for the specific antibodies, the anti-mitochondrial antibody, or PBC-specific anti-nuclear antibodies. And then ultrasound should obviously be done to exclude overt obstruction in the setting of cholestasis. So a secure diagnosis of PBC can be made based on elevated alkaline phosphatase and the presence of the disease-specific autoantibodies. Most often it's AMA, which is positive in 90% of patients, at a titer of more than 1:40. Adult patients with cholestasis, you obviously want to make sure that there's no alternate reason or alternate diagnosis. A liver biopsy is actually rarely required for the diagnosis, and it can actually be misleading at times because the disease in patients presenting, especially in the early stage, can be patchy and non-specific. So a liver biopsy might miss the diagnosis, but nevertheless, it can be performed if the disease-specific autoantibodies are absent, or again, if there's a concern for overlap or another liver disease. So if the liver biopsy is performed, the features are that of chronic non-suppurative destructive cholangitis with epithelioid cell granulomas that are adjacent to the damaged bile duct, and this is termed the florid duct lesion, which is pathognomic of PBC, but it's actually infrequently observed. And then obviously, if untreated, it can go on to progress to destruction of bile ducts, fibrosis, and biliary cirrhosis. So guidelines concur that immediately following diagnosis, patients should be offered UDCA therapy. UDCA is approved as first-line treatment for all patients with PBC, irrespective of disease stage. And it's simple, it's safe, and it's effective, and it improves liver transplant-free survival. It's dosed at 13 to 15 milligrams per kg, and it should be continued for life. So despite its proven efficacy, about 40% of patients have incomplete response and they require further treatment. Importantly to also note is that UDCA doesn't impact on the symptoms of fatigue and pruritus, which are common in patients with PBC. So at the time of treatment initiation, it's also important to take into account risk factors that might suggest a poorer prognosis. Patients should have non-invasive fibrosis assessments, baseline bone density scans. You should obviously treat any coexistent autoimmune or metabolic disease. And importance should be placed on symptomatic treatment of complications of cholestasis and cirrhosis. We obviously don't have time to go over all of that. And then treatment of the patient's symptoms, because that's what the patient is going to be complaining about. The algorithm for the treatment of pruritus is very similar to what we've already discussed for PSC. But essentially, after 12 months of treatment with UDCA, patients should be reassessed. And there's some more recent data that suggests that assessment could even be made as earlier as 6 months, but nevertheless, that's not yet in guidelines. So 12 months, you assess response, and the response, you look at the PARIS-2 criteria to assess if patients have responded. So there's improvement in the ALP and bilirubin. And this improvement is associated, obviously if they don't improve, it's associated with disease progression, and those patients should be considered for second-line treatment. So the traditional second-line treatment has been obeticholic acid. It's a primary human bile acid, chenodeoxycholic acid. It's derived from there, and it's a ligand of the farnesenoid X receptor. It received its FDA approval, accelerated FDA approval in 2016 when it met its primary endpoints in the POISE trial. But with safety concerns regarding the exacerbation of pruritus as well as exacerbation of liver failure, that led to a black box warning that we should avoid it in advanced cirrhosis. And also patients, researchers failed to show improvement in a mandatory post-marketing phase 4 trial. And as a result of that, at the end of last year, the FDA actually declined to grant full approval for obeticholic acid. Another off-label option, it's not widely available, is the pan-PPAR agonist benzofibrate, which can be given in combination with UDCA. It's actually been shown to be quite effective in studies, but there's concerns about increasing ALT and AST activity, as well as increasing creatinine kinase levels. And this, obviously that may put patients at risk of myopathy and rhabdomyolysis, especially if they have underlying renal failure. And then, as mentioned earlier, benzofibrates in the FITCH trial did show to improvement or reduce cholestatic itch. So with limited second-line treatment options, it's refreshing to have these new drugs approved that offer a kind of treatment paradigm. You get the peroxisome proliferator activated receptor agonist. It's a mouthful, but PPAR agonists that are functionally similar to fibrates, but they have unique structure. They have highly selective binding activity and potency. There's 3 isotypes of PPARs. You have PPAR alpha, PPAR gamma, and PPAR delta, and each are encoded by different genes, and they work on specific tissues, and you can see that they've got various modes of action. You can see on the slide various modes of action. In 2024, 2 new agents in this class joined the treatment armamentarium for PBC. The first one, elafibranor, which is a dual PPAR alpha delta agonist. It met its primary endpoints of biochemical remission at week 52 in the pivotal ELATIVE trial that included 161 patients with refractory PBC. And not only that, that showed ALP normalization in 15% of patients, whereas 0 was seen in the placebo group. But there's some important caution that's needed in patients that are on concomitant statin treatment, where there's an increased risk of myalgia and rhabdomyolysis. And obviously, these drugs should be avoided in decompensated cirrhosis, pregnancy, and breastfeeding. And they also may have some potent drug-drug interactions that one should be aware of. Seladelpar, it's a PPAR delta agonist. It's a second agent in 2024 that was fast-tracked and approved by the FDA for the treatment of PBC. The study design was very similar to that of elafibranor, and again met its primary endpoint of biochemical response at a rate of 61.7% versus 20%. And AALP normalization was also seen in 25% of patients versus 0% in the placebo group. And in this trial, the key secondary endpoint, which wasn't met in the elafibranor trial, was that the pruritus scores in patients actually improved, and that was found with statistical significance. So we're still really awaiting real-world evidence and guidelines that will give us, obviously, guidance on how we are to sequence these new drugs. So lastly, just to touch on overlap syndromes, a PBC autoimmune overlap. Patients with autoimmune hepatitis features can be seen in 8 to 10% of patients with PBC. A liver histology, obviously, in this case is mandatory because the Paris criteria actually takes into account both the biochemical and the histological features. And when the score is added, it provides quite a good sensitivity and specificity for the overlap. And obviously, these patients are at risk of actually a more accelerated path to fibrosis and cirrhosis. So they need to be promptly treated with cholinergic treatment as well as immunosuppressive treatments. And in the variants of autoimmune hepatitis, PSC overlap, this is a rare condition, usually varies according to age. There's an intent to evolve over time. And this picture is a predominant picture seen in children and young adults, with a prevalence of around 25%. And despite biochemical improvement that can be seen when you give immunosuppressive drugs, the transplant-free survival is actually similar to that of classical PSC, and it's lower than that of pure autoimmune hepatitis. So just to be aware that these variants do exist, and we should consider them when the pattern of LFT suggests that there could be a component of both. So to conclude, autoimmune liver diseases are complex diseases, far from being elucidated. The etiology is still obscure, even though there's major progress that has been made. And it's important to have an approach to a problem of an abnormal LFT and always consider the differential diagnosis of autoimmune liver disease and be aware of the various presentations and the risk of progression in the context of evolving treatment options. Yeah, thank you.
Dr. Gaskin, that was truly magnificent. Touched on all the practicalities, and I think everyone here is comfortably informed about autoimmune liver disease. Unfortunately, we still don't have many options in Mzansi, and therefore we do with what we have. And I mean, I'm reminded somebody in the comments privately messaged me to say, to echo that in our population or in our continent, unfortunately, most of these conditions are picked up very late, and therefore by the time patients present even with autoimmune disease or even biliary disease, they already have established advanced fibrosis and or cirrhosis, so there's no time to really play around with treatment. None of us here go for routine blood testing. We wait until we are ailing before we go get and tested. And None mentioned the upper limit of normal versus 50. Guys, any abnormal LFT needs an explanation. And if you don't have an explanation for that, you must look harder. Remember that people with advanced fibrosis might have as little as an ALT of 40, but might have really significant underlying liver disease. And I think judging from the engagement in the chat group and the fact that this talk is recorded and will be available for people to actually listen to it at their own leisure and go through it and scrutinize it, and perhaps email myself and Jill and ask further questions. I'd like to thank you again, Jill, for an incredible 1 hour. I want to thank ECHO University of Mexico and ECHO India for the support. And as mentioned, this recording will be available on the website, Castro Foundation. And thank you. The next talk will be on the 31st of March, and it will be presented by John on metabolic associated steatotic liver disease. And chairing that session will be none other than Wendy Spearman. Good evening, everyone. Have a lovely Monday evening.
Thank you.
Thanks.
Bye-bye.